Hi, we're back. Did you get your coffee? I got more coffee. There's never enough coffee. So it's 10 o'clock, and we are going to be welcoming our program director for social determinants of health, my favorite redheaded Canadian, Lisa Nicolau. And she will be introducing our star-studded panel. I hope you enjoy learning about this brand new it's like the Wild West for us here with these social determinants of health. Director Hertzel said that we really needed to understand who was gathering this data, and that we needed to bring it together and not be duplicative, which means that we need to partner. We need to partner with the social sector, and let's figure out how we're going to do that with this next panel. Hi, Lisa.
Hi, how are you?
Great. Thanks for being here. I can't wait to see what you guys have planned. Are you going to get into it? Is it going to get really?
We're going to get into it. We're going to get real.
Okay.
And again, the first little part is not the meat and the potatoes. The real part is our lovely panelists, but we will get there. So welcome today. Thanks for joining for this discussion about cross-sector data sharing. My name is Lisa Nicolau, and I'll be co-hosting our session today. I am a new face to MyHIN, but I have been involved in the work throughout the state, both from a provider organization and from a cross-sector data sharing perspective for the last 10 years. I was completely moving in a different direction when I moved to Michigan, and I saw this ad for these national demonstrations. I'm like, geez, could this be the start of the big change? As a Canadian here in the US, it has always felt a little on the strange side, but I thought, geez, is this the start of the big change? And if it is, I really need to get a piece of that action. So entered into the provider organization world through the MyPIC demonstration, evolved into the SIM demonstrations, so on and so forth. I came to MyHIN just in June of this year and found my place as the program director for the Social Determinants of Health program that was founded in August. The universe has collided in the last 2 years and it has driven the urgency and increased interest in data that identifies health-related social needs, documents referrals to community care teams to both navigate and assist in meeting those needs, as well as to identify what interventions impact needs most effectively, therefore ultimately impact healthcare. This range of data can lead to change in social environments known to impact healthcare outcomes substantially, potentially more substantial than medical care. Collectively, that's known as the social determinants of health. With the ongoing effects of the pandemic highlighting the inequities in health, gaps in social support systems, and the economic fallout felt across Michigan and nationally, the attention that social care brings to healthcare quality and cost is welcomed and overdue. Today's discussion is really meant to better understand what the current landscape is, both here in Michigan and nationally, and to provide real-world perspectives on what the next steps here in Michigan should be from leaders whose jobs puts them on the forefront, on the front lines of this work daily. Next slide. We're going to do a brief introduction here to make the faces familiar, and we will give each panelist a little bit more time later on to introduce themselves more comprehensively. First up is Greg Bloom. Greg is the co-founder of Open Referral and a consultant to the National Gravity Project. Next is Maureen Kirkwood. Maureen serves as the executive director for HealthNet of West Michigan, which is the grantee for CMS's Accountable Healthy Communities project of Kent County. Last but not least is Ken. Ken Toll is the president and CEO of the Jackson County United Way and co-led the work group that developed the Jackson Care Hub screening and referral tool. Next slide, please. My co-host today is Dr. Mike Klinkman, who I know first and foremost identifies as a primary care physician and works through his practice with patients, his teaching position with the University of Michigan, and is a long-term consultant with many projects here in Michigan, nationally, and internationally that integrate social care information with healthcare. Dr. Klinkman has been a long-term consultant to MyHIN and as the National Gravity Project as well, and has recently formalized both of those roles as MyHIN's new Social Determinants of Health Program Director and the Gravity Project's Technical Advisory Committee Co-Chair. Welcome, Dr. Klinkman. Next slide, please. Our agenda is going to be fairly simple and straightforward. We're going to start with a look at where we are here in Michigan. What is that current state? We're going to look at historically how we got here, as well as focus on the national influences that we're feeling here in Michigan. We're going to do a brief overview of what the Social Determinants of Health program is working towards here in Michigan. And then we're going to introduce our panelists and really kind of get to the heart of the conversation. Next slide, please. Certainly this slide does a great job relaying the complexity of healthcare data today. Pockets of data exist in many locations and really reflects the complexity of the system of care. The more complex the system, the more pockets for data to live in. Yet that data combines to give the wide views of individuals and populations, which teams, both social and healthcare, really require in order to develop those collaborative, person-centric treatment plans that we talk about, as well as align with national standards. While this represents complexity, it doesn't represent the chaos that was very much present 10 years ago. The state of healthcare data 10 years ago was not well organized. It lacked standards. It lacked the granularity to really reflect clinical quality improvement beyond cost comparisons, and certainly was held in silos that kept each individual organization managing quality improvement efforts as it related to their own small world. That kept that wider person-centric approach from really being realized. A concerted effort was made to standardize the data, create the granularity needed in the clinical setting. With improvements in that data came that ability to exchange, to compare, and to use that data to better understand needed changes. Quality improvement efforts gained momentum and changes happened that did improve care. Lather, rinse, repeat, and multiple times over. And the data has steered us to the point where we're at now, looking at the role that social care plays in better understanding health outcomes, lowering the cost of care, and achieving that triple aim that has been a little elusive to date. The attention to the role that social care plays in attaining better health outcomes would not have happened without the data. How social care fits into this network of networks is still being sorted through. Next slide, please. When we look at the evolution of social care data and the care processes, we really need to jump back about a decade. We want to be clear that this is looking at social care through the lens of healthcare. Social care by itself has existed in the community for as long as healthcare has been around, potentially longer. The evolution of the data in healthcare allowed to cross-organizational care. The evolution of data in healthcare allowed that cross-organizational care comparison. With that ability to aggregate data in a different way came the onset of alternative payment models, moving from that fee-for-service to fee-for-value structure. Those care models and those payment models really dictated a different data flow. And so MyHandCrew was created to ensure that the effective technology and those data standards were in place to allow that flow to happen. Standards that here in Michigan we take for granted now, but at the time felt foreign. They felt difficult and treated with a level of wariness. Note to self, if you ask clinicians now how they feel about ADT messaging or how it compares now to how they manage their patients in transition between two or more locations, and they couldn't live without it. Demonstrations from a federal level are brought into Michigan around 2014. Care evolution continues away from evolution continues. It moves beyond the capacity of a stronger primary care foundation and into how do we coordinate care with partners, both within healthcare and partners that are external to healthcare in the community. Brings that community into focus. For some, the state innovation model was part of their evolution, and for some, it was less clear. Unique to that state innovation model demonstration was the creation of 5 community health innovation regions. They were meant to act as catalysts and stimulate and drive the accelerated collaboration and systems change between social and healthcare entities, but not through a single approach. A single approach has not worked in the past. Each region used innovation and various process change levers available in that region to create their models. With this work came the recognition that there were no standards in place currently to be able to aggregate and compare data from social care. The Gravity Project was introduced in 2018. It launched as a multi-stakeholder public collaborative with the goal of developing, testing, and validating standardized social care data for use in patient care. And you can see that healthcare focus in how the Gravity Project work initiated really comes through. That's being evolved to be more inclusive of social care partners. New technologic standards at the same time were meant to manage consent, data exchange through FHIR, et cetera. These were also evolving at the same time. MyHIN's first foray into data aggregation came towards the end of SIM as that first SDOH use case was launched. This was specific to the state innovation model approach and was developed solely for that purpose. MyHIN's now on their second evolution, third total evolution, and it continues to evolve as that Gravity Project work evolves and as we receive feedback and learn about our environments here in Michigan. Next slide, please. If it's not clear, let me reiterate, no one has figured this out. There is no one solution we can put in place and go, voila, I have the answer. Not the case. As more is learned, care evolves, capacity evolves, the drivers for this type of change and data evolves. Certainly with the fallout of the COVID pandemic, straining financial and human capacity across sectors, the frenzy has really only increased. We have to take care, however, to not only get the data, but do it in a way that doesn't jeopardize the fragile balance that exists in both sectors. This is especially critical with so many depending on that social care system that exists today. The recognized barriers that have been identified to this cross-sector data care is really critical to mention. If we think of social care as where healthcare was 10 years ago, we can understand the challenges that they're facing now with underfunding, lack of infrastructure, multiple silos to bring together, lack of standards. Understanding what data metrics could be used to evaluate that care that crosses both sectors and identifies the value that social care brings to healthcare. Next steps. And then we get to HIPAA laws and how data in this sector is governed. We don't have HIPAA laws were never intended to really cover social care data. How that data governance evolves will impact the environment and ultimately the results and effectiveness of the future state. Creating that right environment, which allows the data to flow, will impact metrics that are identified. It will stem from data governance as those two sectors join forces and learn from each other. Not playing out here just in Michigan, but nationally as well. These are the same issues that we're seeing at a national level. Michigan may be further along because of the demonstration efforts early on. All of this represents a big opportunity to evolve care and impact health outcomes, healthcare costs, and health equity. Next slide. I'd like to, I think our slides are a little out of order. Dr. Klinkman, do you want to take over here?
Sure. Hi, everybody. We are trying to align the work in Michigan with the work done nationally. And Lisa mentioned the Gravity Project. What's important about the Gravity Project isn't just that you're creating a standard that everybody around the region, around the country might follow for content, but you're trying to work from a common model, a common data model for how care ought to be delivered on the ground level. This picture, which is kind of complicated, is a good way to think about that. It shows the same care model that we often use in healthcare, from screening to diagnosis, to working with a client or a patient to set goals, and then to intervene to fix the problems that we identify. So here we are with this care model that Gravity put together that consists of, at the very top of the circle, screening, the things that we've talked about, seems like incessantly for the past couple of years, social determinants of health screening to take place in practices, but it also takes place in community, takes place in a lot of areas that we don't currently actively work with. There are standards that are being developed for those screening results. Most of them are using the language LOINC, and those observation codes can standardize what we learn. If you move along this circle to the right, you see the diagnosis circle. And we've struggled in healthcare about using what we even have in inventory with ICD-10, CM, Z codes, which cover social problems. Gravity has worked on expanding and standardizing that set. When you move on to the goal setting, that's a different provenance entirely. Those are care managers, care coordinators, people working in community with clients or patients individually to set their goals for what they want to achieve out of care. We're trying to learn what standards might be built there so that we can share that information. And then finally, as you move over to the right or to the left of the screen, the interventions that we're trying to come together around are often things done in community, not in healthcare. They are a community action agency providing temporary housing for someone who is homeless. They are things done to provide food and transportation services when necessary to people who are in need. Those things we don't do in our practices, but they're things that we want to know about so that we know that our patients' needs have been met. Those standards have yet to be built on the medical side, but they've been in place in the community side for years. One option is the LA 211 AIRS taxonomy that is used by many social service agencies and many 211s. Point here is that to work together will require a big village, and it will require us moving systematically through being able to name what we do and simply exchange messages and coded language about what we did. So next slide, folks. This shows what is the landscape in Michigan on the community side. Many of you in the audience know that there are now many different vendors that have built and are marketing social services navigation platforms that can connect to, or at least propose to connect to, electronic medical records. In Michigan, we have active instances of Aunt Bertha, Riverstar, NowPow, Unitas, and there are many others. We could clutter the slide literally with the names of the applications that are in use in the state, which has led us to try to make sure that we don't try to create a one-size-fits-all or a one pathway must be adhered to for everyone environment here. In Michigan, we're hoping that we can use what people already have on the ground. We can create a standard for moving information between applications in community so that we are vendor agnostic, but content standard. That's the fine line and the needle we're trying to thread in this work. Next slide. I think, Lisa, this is back to you, I think.
I actually think I may have done this one earlier. You'll see some familiarity there.
Well, we can focus, just
Whoops.
we're among friends, and we can focus on the big picture things here while we build, while we drive or fly. It's hard.
Exactly.
Yeah.
So it's really just reiterating that idea that there's no solution in place. There's not a one size fits all. There are issues that we have to really build out while we're driving this bus. So if we're going to meld social and clinical care, we have to deal with that idea of getting data to flow. What are the environments that allow us to make that data flow happen? How do we merge these two very distinctly different funded, different organized, different everything systems of care? And it hasn't been done before. So we really have to kind of work with that partnership. The idea of evolving those healthcare metrics that we can really use to provide that, or to show the value, and then to create that data governance that really that allows us to make that data flow happen. So lots going on there. Next slide, please. I'd like to think that Mayhin's leadership really was had a good foresight going on. The data that surrounds the social care model and social determinants of health can be revolutionary as we move forward. And it has to be managed very carefully. So I'd like to think that as they created that social determinants of health program, they recognized the role that it will play going forward and really decided to dedicate some significant emphasis to it. Mayhin's role in this whole process is to guide that data model development, ensure consistency with national standards, support the regional work, to get data flowing, create those environments in advance of the national standards being fully in place. If we wait until those national standards are fully in place, we're going to be behind the scenes. So we really have to do it as they are evolving. We need to create that right environment that allows that data to flow with data governance. And then we need to ensure that the data is being returned to end users in a way that supports care teams, patients, payers, the full spectrum of stakeholders that are invested in this work. And we really need to quickly move past gathering screening data and towards that idea of interoperable data, interoperable referrals, and more full care evolution. We need to understand that data metrics could be used. I think I'm going off again. So next slide.
Some people have seen this picture before. This is a pretty high level picture. And as the slide keeps building, hopefully it keeps building, there are two different ways that you can engage community in this work, basically. One of them is if the community on the left is the recipient. That's where a health system or a healthcare enterprise reaches out, finds community organizations to work with, then creates one-to-one linkages so that they can exchange data. The community is a recipient of some largesse from the healthcare system. The use cases are built around what healthcare needs. And it's a tough way for community organizations to join into this process because the next healthcare system comes along, creates a different model and a different set of connectors, and the community organizations have to scramble sometimes to meet different requirements from different potential partners. On the right is a bigger picture, a little more complicated, but it's when the community participates in this process with designing solutions that work on the community side where a lot of those interventions that we talked about earlier take place. The community then decides how to connect to each other and then how to connect back to healthcare. That's community as partner. That's a much harder thing to pull off. That's something we've been working on for years. You're going to hear about some of this from Greg Bloom in a minute. This is the stuff that we're trying to reach toward, I think, in general, but we know that not every place can invest the energy, time, resources, and has the trust to pull this off. Can we see the next slide? The features of what we're calling, in some cases, a community-partnered clinical information exchange or community information exchange in the form of a community care hub has been attempted in many places in the country. Not yet done well, but the common parts of it, you can see in this slide. There's some co-design work done to come up with a common care model. You saw that picture with the gravity picture a little bit ago. There's a resource directory or resource database at the core of this that identifies those community service organizations that are participating and available to people. In the case of some of the work in the SIM project, that was 211 in Michigan. And then there is an application, an infrastructure, a technical piece in the middle that we're calling a community care hub that contains some of the social services navigation features, the ability to create an electronic referral message, just as we do in healthcare, only to community side recipients. And through that hub, we're hoping is the point of connection to a broader, regional, larger, scaled up enterprise that MyHIN can support and move data to. So pretty simple building blocks. Healthcare on the left, hub in the middle, community on the right. This stuff can work if done with careful alignment and with a heck of a lot of trust. I think with that, we're close to the end of what we wanted to set you up to talk about with some of our community partners. So next slide. This last picture gives you an example of what can happen in the future. We know that in a multi-platform world, there are going to be different products, different technology solutions in use, and connecting them to the hubs that we envision, and then in turn, using MyHIN as a plumbing, wires, and standards to move the data so that it can find second homes is a way that we can accomplish this. Okay, we've talked more than enough. Let's see, what's next? Next slide. Yeah. Lisa, you want to set this up before we go to our panelists?
Sure. Just know that in January of 2022, we're really going to be working towards these social care organizations, clinical and government entity workshops, each with their own space to be able to level set on national and state trends, get the feedback that is really needed to be able to move us forward about what those biggest barriers are, and identify concrete next steps for each sector. It's ultimately, we need to work towards a consortium to advance that cross-sector data exchange. That the ultimate will be to move towards that data governance model in a collaborative way, create that bidirectional social determinants of health data exchange, and then move on in towards interoperable referral pilots with rapid cycle development to really kind of even it out, making it easier for care teams to adopt. Next slide. So as Dr. Klinkman has said, we've talked way more than I would like to. I'd like to introduce our panelists, or actually give them an opportunity to introduce themselves. First up is going to be Greg. Greg, we're going to ask you to introduce yourself, but when you're done introducing yourself, everybody's going to have an opportunity to answer the question from your perspective: what has gone well in the projects you are involved in the state of Michigan, and what are the positive aspects occurring in this state? So go ahead and take a few minutes to introduce yourself, and then if you could answer that question.
Okay. So hi, I'm Greg Bloom. I lead the Open Referral Initiative. Open Referral develops data standards and cooperative strategies for the Resource Directory Information Challenge. And I came to this work from the District of Columbia. I worked for a large anti-poverty service organization serving local stakeholders, local people in need. And I found these problems just within the organization. This was 10 years ago, and I watched many attempts to solve them through technology and observed that nothing was really working, even though more and more resources were available to try things that clearly weren't working. And learned the hard way that really it's to only somewhat sarcastically put a glib point on it. This journey is really about the friends you make along the way, rather than about the tools that you deploy. Towards that end, I have not yet actively participated in what's going on in Michigan, but I've heard a lot from Dr. Klinkman and also from partners in 211, and I'm really impressed. I think, first of all, going years back, there was leadership from the government to support the development of the 211 resource directory referral infrastructure, which I think is the kind of thing that governments everywhere should do, and in Michigan it happened. And I've heard from Dr. Klinkman. I've seen some reports from conversations among service providers that have been happening over years about how really it's the work with the service providers that is going to make it clear what ought to happen. Rather than trying to disintermediate the people who actually do the work of helping other people, ought to be involved in the planning and prioritization of what happens to improve these systems. And I think that's really impressive and less common than you would think. And I also see in this presentation I've seen here really simple language, which I just appreciate. I still see this framing of SDOH interoperability, which I find that is one of the barriers in the field, is the jargon of this term that came from academia to address policymakers and other healthcare stakeholders about systemic issues is being inflicted upon people who really have no reason to wrap their brain around why they're saying the word social determinants of health to describe something like connecting people to food pantries and such like that. I see really clear, simple language that's not burdened by jargon, talking about how healthcare and social care can and should more effectively work together. And I just encourage that kind of accessible approach to common sense thinking through issues that are otherwise often clouded by techno mumbo jumbo and magical thinking about market incentives and whatnot. Really, what we need to do is get people together and have them talk to each other. And I'm looking forward to joining those conversations.
Great. So I think, Maureen, you are up next. If you want to take a few minutes to introduce yourself and answer that same question. What's going well?
Hi, everyone. Thanks, Lisa. I'm Maureen Kirkwood, the Executive Director of HealthNet of West Michigan. We are a bridge organization. So our role is basically to navigate care and connect resources. That's our mission. We work between the formal healthcare system and payers and clinical delivery sites and help navigate patients, community members to the broad network of community-based organizations. So we're sort of that hub model that Mike was talking about earlier. We are the recipient of the Accountable Health Communities grant from CMS. So we've had a lot of experience in the last number of years navigating about 6,000 patients per year. And doing that connecting. We have a team of community health workers and social workers that does that work. We are also part of our homegrown network, which I think is what we're going to be talking about a little bit here, called the GRACE Network, which is an acronym for Gather Resources and Align Community Efforts. And this is a locally kind of curated network that we're gradually building. And to Mike's earlier point about them being local and how important that is, it's really about that. So I think one, to answer the question about what's going well, I think the holding off on the part of the state to impose a one-size-fits-all model is very wise. The local work of bringing stakeholders on is really, really important and vital work. I think that this work, we have definitely built a stronger bridge between community-based organizations and healthcare. Prior to this work, I think community-based organizations were like, well, yeah, the big healthcare system, and please pay attention to us and communicate with us. And that's really some of those barriers have been eliminated. And I think that just the empowerment of the community-based organizations to be a full player in the conversations is really important, as is making sure that we're bringing the voice of the patients into this conversation. Because again, this is all about their lives, their health, their well-being. And if we don't have them part of the conversation, then none of this is going to really make a difference. So that's my perspective for the first question. Thanks.
Great. Ken, do you want to take a stab?
Yeah, good morning, everyone. It's a pleasure to be here. I'm Ken Toll. I'm the president and CEO of the United Way in Jackson County. I actually joined the United Way 20 years ago. And for those of you who don't know, United Ways are sort of interesting nonprofits. Our mission is to mobilize resources to meet the needs of our communities. So we do not have a agenda or a mandate from on high. We simply work with our local resources and our local partners to try to figure out the biggest needs we can resolve and move them. When I joined the field 20 years ago, there was a real robust conversation going on across United Ways pertaining to the fact that we spent a lot of time and effort trying to invest in the right services and make sure the most needed services were supported, but people didn't always find those services, and that didn't create the outcomes we wanted. It did no good to fund the right programs if people didn't know where they were. And so the first thing I saw on my desk when I joined United Way was a memo from Atlanta saying, we just created this thing called 2-on-1. We think it has legs. We encourage other United Ways to experiment with it because maybe the FCC will allow us to keep the 2-on-1 designation as a shortcut for health and human services info and referral. So 20 years ago, our network began trying to develop 2-on-1 contact centers around the country so we could connect people with resources. It really was an expansion of our mission from funding services to actually facilitating access to those services as needed. And that led us to learn more and more about how people often need help and guideposts to get to these services. Obviously, pre-Google, it was the Wild West, and a lot of folks just never found the services they needed. We heard heartbreaking stories all the time about that. At the same time, in Jackson, our health network was pretty progressive. They were in the process of consolidating and buying a lot of private practices and forming our Allegiance Healthcare Network. And they formed something called the Health Improvement Organization, deliberately to be a bridge to community providers as well. And so I've been around a table for 20 years with our local health improvement organization talking about how do we address things which ultimately proved to be social determinants of health. So we had a long track record in Jackson of meeting, of talking with our healthcare system, of trying to find these bridges. And when the SIM grant came along, we were happy as a community to jump on that. There were already several of us at the table looking at an Accountable Health Communities grant, and SIM was more flexible and more germane to what we wanted. So we actually pivoted our project mid-course, contracted with Dr. Klinkman, and he and I led a work group which actually developed the Care Hub model. I noticed it wasn't capitalized on your slide, Dr. Klinkman. Remember, CARE stands for Community Assessment and Referral Exchange. So it works at both purposes, but the Care Hub is actually created to be a social determinants of health screening and referral network that closed the loop. So us nonprofit providers knew if the medical care was happening, and the medical care providers knew if the nonprofit care was happening. Literally, that feedback was very important to us. So what's gone well locally? A couple of things. First of all, I think it's great that Michigan is leading this dialogue strategically. Having MyHIN at the partner talking about standards and interoperability as communities try to figure this out is really critical and essential, and it's going to give us a big leg up in terms of getting this work done correctly. In terms of our own project, I think what I see is a massive participation rate. We have screened about half of Jackson County residents, and that's far greater than we thought we would get to. And it's really because the healthcare providers have adopted the technology. We're finding that the healthcare providers love to do the screening and ask all their patients if they need help with food, if they need help with housing. Conversely, the community-based organizations were less excited about doing that work. The screening has been a burden to them. They don't have the technology, they don't have the time. And I was afraid that may jeopardize our project because the CBOs haven't operationalized the screening. But what we found is the healthcare providers have totally taken that ball and run with it. They're screening everyone, and the referrals are now flowing freely through to our community-based providers in a very coordinated and strategic way. So I think we've demonstrated that the workload can be shared across these domains, all for the common good of connecting the information and the clients to what they need. And finally, I'm really pleased that we've built a massive store of data now. We have all kinds of repeat assessments in some cases of folks who've screened positive for needs, have gotten referred to services, and now they're not screening positive for those same services. It'll be very interesting to see how that changes their healthcare outcomes and future healthcare spending. So I'm here because I would love to have access to the healthcare funding that comes with the SDOH screening. As Mike said earlier, the medical community is more well-funded, and the nonprofits could definitely use some support by better integrating. We can do the work, we just need the resources.
Wow, these are great statements, yeah.
Yeah, really good.
Now comes the others. The next one, yeah.
Next question. So now that we've seen the positives, what are the barriers that you see as hindering that process in cross-sector data sharing or care model evolution? Maureen, do you want to kick us off?
Sure. I don't want to be Debbie Downer or anything, but there are definitely a lot of issues from the community perspective. I think that to Ken's point that he just made, the funding, certainly our healthcare systems have been under gigantic burden recently because of COVID, and that's still continuing, obviously. And so it's not like they're rolling in the dough and the resources. But there has been a feeling of that it's being driven. There's a tendency for healthcare to want to drive this. And I think it really has to be a much more collaborative type of process. I think the coordination across sectors is very challenging. It's one thing to click a box and send a one-off referral to a food pantry or a food resource. It's another thing when you've got a highly complex community member who needs navigation for multiple systems, housing, mental health, substance abuse, domestic violence. I mean, there's so many different systems and they're all separate. And I think that's a huge, huge issue. I think the other piece that I'll mention, and then I'll let others chime in, is those of us in community-based organizations, we're often required to do duplicate and even triplicate data entry because of the funding that we receive comes with mandates to enter data a certain way. And so adding yet another platform could end up being quite a burden for especially smaller and less well-funded community-based organizations. So, and then I think the final thing would be, who owns the data? Whose data is it? Is it healthcare systems data? Is it the patient? community members' data. I would argue that it is. And so all the issues having to do with confidentiality, with attaching social needs data to payer data, there's a lot of concerns about that on my part and on the part of others. So that's my initial response to that.
Thanks, Maureen. Greg?
And Greg, talk nationally as well, because this isn't just a Michigan thing, these barriers. So you had vast, broad experience nationally in looking at this stuff.
Well, I'll offer some fairly high-level remarks. First, I'll just talk about the resource directory piece of this puzzle, which is what I work on specifically through Open Referral. The challenge, the reason resource directory information is hard, by which I mean information about human services, social services, any program available to people in need. I'll give you like a clear view right at the root of the problem. Organizations that provide services to people who don't pay them for those services don't have strong incentives to be listed in all of these different resource directories. Right?
Signing up for more volunteer work isn't a real winner. Yeah.
People don't understand that they're often not paid by their funder per person they serve. And I know there's a lot of interest in arranging for a reimbursement from healthcare payers for social services, but that's happened before, and it doesn't end up shaking out more often than not, like in a way that covers the cost of the service. So we have to stop thinking magically about this as some sort of market that has some sort of logic that ends up working out well, right? If you want good information, you have to make phone calls. And historically, that's work that 211s have done. Other information and referral providers have done, going back before the internet. And I think that the field has not yet like fully evolved to take advantage of the benefits that the internet offers. There's been a lot of focus on websites and not much focus on information supply chains. And so what we end up with is more and more websites containing less and less trustworthy and sustainable information. And so what Open Referral has done is develop standards for exchanging resource directory information between systems. We first developed them as specifications, but we partnered with the Alliance of Information and Referral Systems, which accredits 211 providers, and they endorse these as standards. All of the software providers that serve information and referral providers accredited by AIRS are expected to use these as default methods of sharing data. That does not solve the problem. It's just a necessary precondition. It's an entrance into a new realm of possibilities, because integrating one system to another to share directory information has now, the cost of those integrations have now been reduced by like tenfold. It becomes a lot easier to talk about partnership models that can serve not just one-off partners, but an entire community with many different information systems. But you still have to figure it out. It's not obvious who should be responsible for what. We have some examples of patterns for institutional arrangements for business models that we know can work, but the precise combination of those patterns in any given community is going to be unique in terms of what the answer of who should be responsible for what. So the next barrier is building the capacity to figure out who should be responsible for what, which often is not something that's funded. Right? The way that funding works is like, give us your plan, then we will give you the money and you'll do the thing and you'll tell us how it went. And what we need is actually the capacity to figure things out. And that's oftentimes a difficult pitch to funders who want to know that you know what you're doing. And we have to figure things out here. And I'm tentatively optimistic that enough institutions have tried other things that haven't worked, that people are now coming around to say, okay, we do need to invest in the capacity for the capacity to build capacity, the capacity to build coalitions and to design new business models that may take some time and effort.
Great segue, to Ken, just because Ken's been doing that work in the Jackson community for a while. Mm-hmm. And Ken, we put 211 at the center of how the Jackson Care Hub was built. But do you want to pick up on what Greg just said? Because I think that's a really important point about how that was done, how you kind of led that work, how 211 has become kind of critical to the success of that.
Yeah, I'm sorry I haven't talked with Greg before. I think this is going to be a long conversation, so nice to meet you, Greg. We started in, in Jackson 20 years ago because we wanted people to have access to services. United Way has invested quite a bit of money in 211 over the years to build out that database. The records do have to be updated regularly. Every single record is touched at least once a year. Programs are verified. So it is a costly proposition to operate. But when you do it at scale, it's not as expensive as it otherwise would be. So I think the answer is to decide 211 or whatever platform is the right one incentivizes nonprofits to play better because they know they only have to do it once instead of 50 or 100 times a year, which some of them are being asked to do now. But we got into the business with this whole process because we volunteered to share that data freely. We built the data so people could have access to better services. And in Jackson County, as long as I'm the director, if a nonprofit or healthcare provider or other public entity, public benefit entity wants to connect with our data, we will make it freely available and connect. We run into some additional complications when it's something like Aunt Bertha or NowPow, which is a for-profit company, which is monetizing those transactions. Our willingness to share the data freely with them will be conditioned on paying, for the access to that data because it's expensive to maintain. So I think each community is going to have a different answer to this question, Mike. But clearly, most of us who are operating 211s want the data to be used if it leads to better outcomes. We just don't want to be part of a for-profit scheme, which is going to basically take all of our work at no compensation and create issues down the road for our sustainability.
So what about, Greg, what about the personal,
briefly, I think skepticism of the incentives of for-profit companies is valid. And also, I think there are mutually beneficial arrangements to be had in which a for-profit company that might be able to offer some valuable services to a community can share some of the value that they capture through that value that they provide with a 211 that provides them data in a way that does benefit everyone. So I hear those concerns. And also I think those concerns need to be held in one hand with in the other, like an insistence that we've got to figure something out. Right?
The potential.
Yeah.
Agree.
So Maureen, how do you handle this? You're a bridge organization. You are providing clinical care navigation service. And you're having to work on the one hand with the resource directory folks, and on the other hand with the personal privacy folks, and on the other hand with the health system folks who want to pay you as little as they have to pay you for the service that you do. So how do you build these bridges in the middle of all this?
Yeah, well, if I had the answer to that, I would definitely.
You had that grant. It should have all been figured out by now, right? Yeah. Like
I
you said,
think,
give us the money, we'll figure it out, and then go away. Yeah.
Yeah, I mean, I think the piece that's maybe missing in this conversation is that navigation piece. So one of the things that is so vital is getting away from just a technology solution, which I know that nobody here is suggesting that technology is the only solution. Clearly, we partner closely with our 211. We use their resource directory, and that's how we, power a lot of our work. The piece that is missing is when you have those situations where you need someone, where clients need help navigating, either because they don't speak English as a first language, that they have cognitive difficulties, they're just overwhelmed with everything. There needs to be someone, a person, an actual person, to walk alongside them to help navigate and break those barriers and do a warm handoff to agencies. And I think that piece gets missed. That's an expensive piece. That you have to fund the people to do that. Now, not everybody needs that. Some people, you can just click a box, give them a piece of paper, they'll call, they got it, they're in control. But a lot of the folks we work with need that. And so I think that to me is the maybe the carrot that can bring people to the table to have the conversation. But I don't have the solution.
Ken, I know Ken's burning to talk on this.
Go ahead, Ken.
Yeah, we actually did implement navigators as part of our SIM effort because we discovered exactly what you're saying, Maureen, that there are a lot of people who have complex needs or just don't know where to start. And it's overwhelming to say, here's 20 nonprofits, call them and get to work. So we actually built into our SIM demonstration project and brought on board, I think, 3 full-time healthcare navigators within our 211 contact center. And there's an easy button in our screening and referral care hub that if there's a whole lot of needs here, hit the easy button and that navigator gets a copy of the file and contacts the patient within 24 to 48 hours to make a plan. And I think that's been really, really instrumental in these difficult cases. Going back to the conversation I was having with Greg, though, when we saw the need for these, we actually approached our healthcare providers in town and said, look, you're about to hire more boots on the ground to work in local communities to support your covered lives. We have the model. Why don't you just fund these navigators? And their response was, no, we're going to hire our own boots on the ground and just tell us how we can get into your hub to get the data. So I do think that solution works. And I look forward to a time when we can better negotiate these things to build these relationships with the providers to do this work.
Well, what we've done in this last probably 10, 15 minutes as a group here is segue into talking about human infrastructure, which is a necessary counterpoint to the technical infrastructure that MyHIN by charter is trying to provide. But what it shows me, again, for the 10th, 15th time in these kind of sessions, is that we cannot solve this with only a technical approach. We have to be very aware of the human needs and the human interactions on the ground that we have to support. And Greg, back to you. I think you said very much the same thing, but how does that work? How can we blend the two, and how can we move forward in the state of Michigan to make sure we don't leave the human infrastructure development behind and impose a technical solution, even with simple building blocks, that doesn't have a hope of being implemented because we don't have the human infrastructure to take it up?
So I'm about to give like a conceptual, meta, pedantic answer. I'm an English major. Just bear with me. I'm going to try to bring it back. I'm going to loop back all the way to something Maureen said at the top, which was that we don't really understand how ownership of data should work. And I think this is true both on the resource data side and on the information about people side. And my humble proposition to this panel and everybody in this field is that ownership is actually not a coherent concept when it comes to data. And that what we need to be talking about is stewardship, right? This is not, this data, like owning data like property doesn't actually make any sense. And the needs that we're talking about here all revolve around stewardship. Who should be responsible for making decisions that steward the data that is actually like not effectively owned one way or another? On the resource data side, it's public information. You can't own public information. On the personal information side, like my information as a patient is all entangled with information about my family, right? And my potentially my caregivers, right? And like I can consent to share my information, but those family members that might be wrapped up with that data, like, do they own my data too? It's not a coherent concept. And because we're laboring under this like basically incoherent concept, the clarity that we need to see, that which I think you all are bringing to this conversation, which is that people need to be involved in like the process of making decisions together in ways that establish stewardship and accountability over data that is ultimately a resource that no one can specifically own. I think if we're clear that the challenge here is stewardship, then we can ask the questions about what are the processes we need to facilitate good, reliable stewardship.
Thanks. That's a good point. I don't know if there are any questions from the folks watching. I know that we're wrapping up on time, and there's a way that we're going to bring this all together in two last final great statements that sum up everything about MyHIN. But in light of that, questions from the floor. Naz, is there anybody who is burning to ask a question that needs to get it exposed to these experts here? Okay, good. So let's wrap up. We're into break time. We know that you all want to take a break, but what we're doing in the next few months, I want everybody who's paying attention to this session to pay attention to. In January, MyHIN will be launching a series of deep workshops for our constituent partners. So the first workshop will be for community organizations and their friends to try to figure out what the issues seen by Michigan CBOs and community service organizations are, talk together to figure out how they want to approach these issues. Second workshop will be for provider organizations, medical providers, because they're on the front line from the other side. What do we do after we screen? How do we make sure that our patients and their needs get exposed and managed? They have a different perspective, and we really want to get in deep and hear what their perspective is. And then we'll be talking to government agencies. Local governments, they have a stake in this too. Ken knows that well from the work in Jackson. We want to, again, explore what is important to local governments and to the state and to the state entities that want to participate in information exchange for the benefit of the people they serve. And once we've assembled that information, we will begin to understand how to untangle these human infrastructure issues and pair them with the technical developments that MyHIN will be pushing for. That's the only way I think we feel comfortable about moving ahead without getting too far ahead of our partners in this space. We also have been checking in all along the way with those people that are always at the forefront of this work, the health plans, the payers, the people who have kind of pushed this work to the forefront for their own perspectives about how they can take part in this much bigger, much broader coalition. So that's where we're headed here. And what do you all think? We got 5 minutes to wrap up. So just reactions, kind of last parting thoughts of wisdom from Greg first, then Maureen, then Ken.
I mean, I think, at an abstract level, I think the question is, how do we learn? How can we most effectively learn about a whole array of things? And then to get one more level abstract, who decides? So those are my key questions: is how do you design these processes so that you can learn what ultimately whatever you can in order to make better decisions in the future? And then the question is, who's in a position to make decisions about what you try to learn and how you interpret what you find? Those are really political questions. And I find that those questions, when we're talking about we don't want a tech first solution and so on and so forth, those questions are what is being obscured by all the conversation about technology and data, right? And so we bring these questions forth. What do we want to learn, and who should be in a position to decide, what we're trying to learn, how we interpret, what we do as a result of what we're learning? Those, I think, are much more productive questions than hoping that technology is going to yield some sort of magical solution to ultimately the problems of living in a society that doesn't really provide the means for people to live with dignity and respect, right? We should put aside childish notions and figure out how are we going to work together.
Maureen, top that.
Can't top it. I would just say that we all need to keep in mind that what we're talking about and what we're spending so much time and so much energy on is putting a Band-Aid on the fact that the horse has already left the barn. I just mixed my metaphors there. But the fact is that what we really have to do is look upstream at why is there so much need? Why do so many people need referrals to food pantries and food resources? Why is housing such an issue? Those are beyond the scope, I understand, of this particular conversation, but we cannot lose sight of the fact and feel like we're, quote unquote, solving social determinants of health, which has been, how some for-profit tech companies advertise their platforms. No, you're not solving anything. You're helping put a Band-Aid on it, and it's very valuable technology, but the community really needs to focus on the why and the root causes of this. So I would just argue that we cannot forget that.
Ken, you got the last word. You got
Awesome.
to overcome a lot of great thoughts there.
No, I think I can synthesize them. It's been great being on this panel. And I think an answer to both of those other points are, we need to have a real conversation about the return on investment for this platform, right? This is infrastructure, and we've just seen at a national scale, people don't understand infrastructure or don't always want to pay for it. But infrastructure is what's needed to make this data exchange work. And this data exchange is critical to serving people without enough resources to serve people the way we have been in the past. So I think anything MyHIN can do to broaden this conversation and to help engage communities in the return on investment. So nonprofits have that incentive to work harder, and we all have the incentive to connect would be time well spent.
Thanks.
Great job.
Yeah. Thanks, everybody. And remember, Greg Bloom, remember Maureen Kirkwood, Ken Toll, you have questions about these issues. They're the experts. Find them. They'll steer you right. We will bring them back as often as we can. We'll connect with them as often as we can at MyHIN. And open to any of you who are out there who are burning to kind of engage in this stuff, contact us. Right, Lisa? Is that?
Agreed.
Oh, okay.
Agreed.
Okay. Well, thanks for your time, everybody. And I guess back to you, Joanne. Thanks.
Hi, just for the record, I was burning to work on this stuff, burning to work on this. I mean, you guys, this is it for me. Like what just happened here is like why I wake up. So thank you. And thanks to Mahin for letting me work on this stuff. And I will tell you that I was burning to work on it. I came to Mahin. I told them I would not work on it. So either I was going to be working on it with them and with our community and with our state and with our payers and with our hospitals and with our POs, or I would be working for somebody else on it. And here we are. Thank you so much, guys.
People think she's joking, but she's not.
No, I believe them.
I can tell.